Hello, everyone. I'm Tiff Bortwood. I'm the Managing Director of Australian Genomics. Welcome to DNA Dialogue, the webinar series where we share new developments in health genomics and hear from international leaders in the field. As we gather for this symposium, let us take a moment to reflect on the meaning of place, and in doing so, recognise that we're coming together today from traditional lands of Aboriginal and Torres Strait Islander peoples. I'm joining you from Naarm, or Melbourne, the country of the Wurundjeri Woiwurrung people of the Kulin Nation. I would like to extend my respect to elders past and present of this land and all the lands we work and live on, and acknowledge all First Nations peoples today. So as you turn an attentive ear to the talk today, please ask any questions you have using the Q&A function throughout the presentation, and I'll do my best to get through as many as I can and put them to our presenter during question time at the end of the webinar. If you're active on social media, we encourage you to use the hashtag DNA Dialogue and also tag AusGenomics. So it's my very great pleasure today to welcome Gemma Chandratillake. Gemma has a PhD in molecular genetics and also trained as a genetic counsellor. At the Stanford spin-out Personalis, she developed a clinical genomic sequencing test to diagnose rare conditions. She directed molecular genetics courses for genetic counselling students at Stanford and California State Universities. She's the chair of the British Society for Genetic Medicine and the Cambridge Rare Disease Network. As course director for the Genomic Medicine Master Program at the University of Cambridge and education and training lead for NHS East Genomics, Gemma works passionately to facilitate the mainstreaming of genomics within the NHS. Gemma, welcome. It's lovely to see you.
Thank you so much for having me.
No, it's very, very kind of you to join us at this ungodly hour from the UK. Some people on the call might have had the pleasure of meeting you at ICG in Melbourne, as did I. So you might see some familiar names coming through the Q&A later on. But I really look forward to your presentation, and yeah, I look forward to the conversation at the end of your talk.
Well, thank you so much. Let me just see if I can share my screen. All right.
Beautiful. Thank you.
Perfect. Okay. Thank you so much. Thank you so much for having me today. I really enjoyed meeting a bunch of people in Melbourne, and it's great to be able to talk with more of you today. So I'm going to be presenting today. The title of the talk is From Cradle to Grave, Systematic Adoption of Genomics in a National Health Service. There we go. So as Tiffany kindly introduced me, I'm Gemma Chandratillake, and these are my affiliations. And just a couple of disclosures to begin with. I'm employed in the NHS, so my job is actually to encourage the uptake of genomic testing in patients in England per the NHS Genomic Strategy. And myself and my spouse do hold shares in several genomic testing and life science companies, and I advise companies who create drugs for genetic conditions. Okay, so in the UK, we have a National Health Service, and this was founded in 1948 after the Second World War. And the service is provided via taxes to all, and it's free at the point of care. And it's a cradle to grave model. So this is how the majority of people in the UK receive their healthcare. The UK is the United Kingdom of Great Britain and Northern Ireland, is made up of 4 nations: England, Ireland, Northern Ireland, Scotland and Wales. And provision of healthcare is devolved to the governments of the 4 nations that make up the UK. And the reason I'm mentioning this is because each of those 4 nations has their own genomic strategy. And what I'm going to be talking about today is the NHS Genomic Medicine Service, that is an NHS England initiative. So in the UK, we have an increasingly diverse population, and in the 2021 census in England and Wales, 2 in 11 people identified their ethnic group as other than white. And the reason I'm mentioning this is because one of the aims of our service is to provide an equitable service. And when we think about genomics, this is particularly important. And it's also just to give people an idea of the diversity of the population, because we're building up an increasingly large data set for research as well. So one thing that's important to mention is that genomics in the UK is more than just a healthcare initiative. So back after the London 2012 Olympic Games, we had a legacy program called the 100,000 Genome Project, which was announced by our Prime Minister as a legacy project to the London 2012 Olympic Games, who at the time was David Cameron. And we have since that point really been thinking about how to strategically utilize genomics within the country. So in 2020, the government launched Genome UK, which is the government strategy around genomics. And that encompasses healthcare, but not just healthcare. It also thinks about life sciences sector and industry, pharma and biotech. And the potential for the UK to really be a world leader in the genomics space, because we do have a strong history of genetics and genomics in the UK, and life science research as well. So this is really seen as a strategic area for the country. And part of that is the fact that we have this integrated healthcare system, National Health Service, which gives an opportunity for genomics as a big data science in a way that other countries don't have an equivalent resource in that sense. So that is the government strategy, which, as I said, was launched in 2020, in the middle of the pandemic. There was still a focus on this area. And then in 2022, we had our NHS strategy. And this really, that's the National Health Service strategy for England. And that really has a vision that we will utilize the power of genomics in predicting, preventing, and diagnosing disease and target treatment to all as part of routine care in the NHS. So this really has an equity of access vision to it. And this sets out the next 5 years of strategy, where we're going to accelerate the embedding of genomic medicine across the NHS. Again, with a vision of being world leading. So the Genomic Medicine Service in the NHS launched in 2018 and has these sort of 5 pillars to it. Again, the aim is to establish consistent and equitable care for the country's 55 million population. And that's really, historical. So it used to be that we had different genetic testing laboratories all around the country, and each genetic testing laboratory had different genetic tests on its test menu. And there was different commissioning around the country. So it was one of those situations of being a postcode lottery, where you lived as to what genetic testing was available and commissioned in your region. And so in 2018, all of that historical genetic testing service was kind of torn up and replaced with a series of regional genomic laboratory hubs. And all those regional genomic laboratory hubs operate to a standard specifications and protocols. And they actually operate to a national genomic test directory. So you can just Google NHS National Genomic Test Directory and you will land on a NHS website that lists all of the tests that are offered across England with all of the eligibility criteria for patients. This test directory covers all of the technologies from single gene tests up to whole genome sequencing with the eligibility criteria. And so the idea is that, any patient in the country, if they meet those eligibility criteria, is eligible for the test as laid out in that test directory. And the genomic laboratory hubs are tasked with providing that testing across the country. The genomic laboratory hubs are supported by Genomic Medicine Service alliances, and these are really sort of groups of professionals who are tasked with trying to implement the service into mainstream healthcare. So at that time, it was also recognised that we had a lot of disparity around research and which patients were recruited or being given the opportunity to participate in research. So if you were receiving your medical care in a large academic centre, you were more likely to be involved in a research study or a clinical trial. And obviously that's not equitable. So there's an ambition within this service to make research much more equitably available. The first aspect of this is that those patients who are eligible for whole genome sequencing according to the National Test Directory are also given the opportunity to participate in our National Genomic Research Library, which is essentially a national genomic knowledge base. It's where all of the data from the 100,000 Genomes project sits, and patients are given the option whether they would like to participate in that as well, and if so, then their data goes into that National Genomic Research Library, which is accessible for academic researchers and also those from industry as well. So it includes the opportunity for things like clinical trial recruitment as well going forward. So this is really the ecosystem of how the genomics is arranged in the country. So we have Department of Health, and Department of Health sort of commissions or runs the NHS. The NHS has national and regional infrastructure to deliver the Genomic Medicine Service, and that's the point at which patients interact with the system through their healthcare. We also have a company called Genomics England, that is a company that is wholly owned by the Department of Health, and that is where all the data for the National Genomic Research Library sits. So they control access to the data for researchers from academia and from industry. And we also have a genomics education program as well, which is now joint with NHS England, but this is a national program aimed at providing educational support for the implementation of genomics, and has commissioned various universities to provide teaching in genomic medicine as well. So how are we doing? Well, we have 55 million people, so there's a long way to go with all of this, but we are systematically offering whole genome sequencing as part of routine care now. We also have a rapid service in the neonatal intensive care unit, or the pediatric intensive care unit. We've been running that since 2019. It started off with exomes, but now is running as a whole genome rapid service with a 40% diagnostic rate. We have a similar service, rapid exome service, running in the prenatal setting as well, with a 40% diagnostic rate. And I should mention that the Genomic Medicine Service has really two main strands to it. We have sort of rare and inherited conditions, but we also are doing a lot of tumor testing as well. So a lot of this tumor testing is available via large panels, and then we have whole genome sequencing for some indications as well. And I should say that this is one of the more challenging areas of implementation, because of the complexity involved in supporting cancer services, rapid turnaround time, and we're also very reliant on histopathology colleagues as well to mark up the slides with the tumours in order to be able to extract DNA from the correct tissues. So when we think about the NHS and what we're trying to do, just to give some context, NHS is huge. It's the largest employer in Europe. It's the 5th largest employer in the world. We have hundreds of thousands of healthcare professionals within the national service providing healthcare to patients. However, we only have about 2,000 members of the British Society for Genetic Medicine. Most of those actually are located within the laboratories. We have a couple of hundred clinical geneticists in the country and a couple of hundred genetic counselors in the country as well. So it's quite obvious that the scale of our genomics expertise doesn't really scale with the ambition of the Genomic Medicine Service. And we've known for quite some time, therefore, that our genomic services will have to be delivered by non-specialists. And this is what we call mainstreaming. So mainstreaming is the situation where not all healthcare professionals need to become genomic experts, but we do need all healthcare professionals essentially to be have enough genomics knowledge to know when testing might be relevant for their patients, and we need them to know how to request it and how to have robust conversations with their patients about having genomic testing. It's not the case that all patients who are eligible for testing can be referred to clinical genetics in order to order tests. So this is against the backdrop of a lack of awareness and a perceived irrelevance amongst the wider healthcare workforce. So this was these statements are from a survey that we carried out in our region back in 2016. So we can see here, this is the first time I've heard of genomics. I'm not sure what it is. I don't really know if it would have any impact on my role. Don't quite know what it involves. My role does not involve genetics or genomics. Not sure what does that involve. I don't know enough about it. I'm not aware of this field. I don't even know what it means. So those are quite common statements that we heard, but we also heard indications that people were interested and that they felt that they needed more training. So some people had some exposure and they'd been involved with analysis meetings, but they felt that they didn't know what was going on because they didn't speak the language. We found that people were struggling to understand genetic test reports. Genetic reports are largely incomprehensible to non-geneticists. I would like a better understanding of them. We found that even our clinical genetics community were struggling with how to understand interpretation of genomic variants. People didn't know which patients should be referred, but people were generally aware that there had been significant advances in the field, but they didn't know how those would impact on their patients and how it would change their clinical practice. So that's kind of where we were sitting in 2016. And this is just to sort of outline at a national level what's been going on in terms of clinician education. So we do have a national genomics education program, and they are taking a multidimensional approach, looking at workforce planning, workforce development, educational opportunities, developing a lot of resources, which is really helpful for all of us out there in the field so that we don't have to develop everything ourselves from scratch. Providing guidelines for the inclusion of genomics into various training curricula, and working at that sort of stakeholder engagement strategic level as well, to raise awareness in the system. So this is just a rundown of the kinds of education training that the national program provides. So you can see that they have actually commissioned master's degrees from several universities. That's the formal education piece. We're at the point of actually establishing a national genomic training academy, and that's sort of underway right now. But also, if we just look at their website, there is an awful lot of e-learning and videos that are available. So lots of courses that people can take, targeted different healthcare professionals in different areas of medicine as well. And then the genomics education program just do a lot of work to raise general awareness in the system of genetics and genomics as well. So that's what's sort of going on at national level. I'm just going to pivot for a moment and talk about our region. So I work in the East, and as I mentioned earlier, the country has been kind of divided up the country of England has been kind of divided up into 7 regions in order to deliver the service, and each of these regions has a genomic laboratory hub. So here in the East, we have a hub with laboratories in Cambridge, Leicester, and Nottingham. So we have laboratories in each of those 3 centres. They act as a hub, and samples move on a daily basis between those laboratories, and data is interpreted between the staff in those laboratories as well. And then this region of about sort of 8-9 million people, you can see on here all of the different hospitals and community providers of healthcare in the region. So we've got about 29 different healthcare providers to interact with, and then obviously the whole of primary care as well. So this is all of the hospitals that we need to interact with in order to provide equity of access to genomic medicine service in our region in the East. I'm just going to talk about a couple of the programs that we've been working on. So this is one program, and it's just an example of a targeted program that is very complicated to actually implement and deliver on the ground. So this is a national program that's been led by the East. It's a sudden cardiac death pilot program. So the idea here is to conduct a molecular autopsy for individuals who die suddenly of cardiac event, with the goal of identifying family members who are at risk for sudden cardiac death due to an inherited cardiac condition. So there are 7 pilot centres around the country, and I should just try and explain that individuals who die of sudden cardiac death would be under the sort of jurisdiction, if you like, of the Ministry of Justice. So not the Department of Health. These would be in the coroner's office, which is part of the judiciary, not the health service. So this is just to explain how implementation systematically can be actually really complicated, because you're having to work across different aspects of government, and coordinate across completely different systems, if you like. So in the coroner's office, there are specialist cardiac pathologists. So the way that this has been set up is that they are able to they need to contact the family of the deceased person to obtain consent to retain tissue, and the tissue that's being retained in this situation is the spleen. And then they also need to trigger a referral into the health service, and we have set up inherited cardiac clinics. So that's where we have genetic counsellors closely working with cardiac services and training up clinical nurse specialists. And then they are able to contact the family and facilitate sort of family history taking and genetic testing for other family members of that individual who has been deceased. So it's quite complicated. This is just an example of one area of medicine that we're trying to systematically embed genomics into, and that we can see that there's a lot of benefit from embedding genomics into, but just to sort of illustrate how complicated on the ground this can be, and at what level you need to be working across different stakeholder groups. So this is sort of early days for this program, but so far 60 deceased index cases have been signposted to inherited cardiac clinics, and 249 family members have been identified as at risk, and 137 have been assessed. So early days, but setting up the pathway, and setting up the pathway can actually be one of the most challenging aspects of these mainstream implementation projects. So I'm just going to mention now one of the other types of outreach effort that we've been experimenting with. We've been trying to use a community of practice model to reach paediatricians across the East. So communities of practice are groups of people who share a concern or a passion for something they do, and they learn how to do it better as they interact regularly. So here it's key that we have a touch point for regular interaction, and we've been working with paediatricians all across the East. So we've been running monthly meetings now at lunchtime. We call ourselves the East Paediatric Genomics Forum. We've been running this for a couple of years. So we have our monthly meetings, webinar series, and we record those, and we have an online platform where we have the recordings and the slides, and we also link to other resources as well. We have about 600 paediatricians that we have identified on our contact list, and many of them have attended our forums. We usually find, even though we've been running this for 2 years, we always have new people on the forum. It's always somebody's first time, as well as having some of our regulars attend every month. We also know that our recordings are being viewed, and that we have over 400 health professionals engaged with that community platform. So we feel that this is a scalable model for those with genomics expertise to support a large number of mainstream clinicians on a regular basis to be able to implement genomics into their practice. And we know at this point that we've got over 100 paediatricians from our region who have actually been ordering whole genome sequencing testing for their patients. And this is actually quite a complicated test, because this test has both a clinical test, but also a research consent option offered alongside it. So this is a completely new type of testing. And we're also trying to offer this test as a trio test, where parents are also providing samples. So this is a complicated test to implement, and we now know that we have over 100 regional paediatricians who have ordered this for their patients. So that was from a standing start. So if we just look at whole genome sequencing ordering in our region, we've been able to pull this data quite recently. And what we've just done is taken out all of the clinical geneticists and looked at some of our just focusing on our mainstream clinicians. And they're color-coded here by the type of clinician, and the bar is actually, it's not the number of tests, it's the number of clinicians, because that's what we're interested in terms of outreach. And down the side here, we've just got our list of our different hospitals across our region. And just what I wanted to draw your attention to is, if we're looking at pediatrics, which is the gold color and the bright red, for community pediatrics, what you can see is a common thread of gold and bright red down all of these different hospitals. So we can see that the outreach work that we've been doing with pediatrics has had this sort of desired effect of providing that widespread involvement across the region in this group of healthcare professionals. So if we look at other specialties, like for example nephrology, we can see that we have got particular champions in particular regions. We haven't done this sort of the same level of sustained regional systematic intervention for nephrology that we have with pediatrics. And this is what we can see where we've got this more consistent uptake with our healthcare professionals across the different hospitals. So in terms of adoption of change, if we're just thinking about pediatrics, we've got about more than 100 pediatricians now across the East have ordered whole genome sequencing. They are ordering other genetic tests as well. We're just using this as a marker because it's a new test. So it gave us a nice standing start to compare against. We know that we've got over 600 regional pediatricians on our contact list. So we think we're sort of at this stage on the adoption of change curve, where the early adopters have uptaken this testing now and have really changed their practice. And we're into this kind of area where we're sort of hitting the majority of these healthcare professionals. Okay, so I'm now going to talk about a couple of pieces of research that are going on. So if we think about genetic test reports, we had the comment from our survey: genetic test reports are largely incomprehensible to non-geneticists. I would like a better understanding of them. So this is a piece of research that was done with students at the University of Cambridge. The idea being that for genomic testing to deliver maximum benefit of patients, the results must be actioned appropriately by clinicians and disseminated accurately through families, and therefore the test results need to be presented to ordering clinicians in a way that they and their patients can understand. And we know that non-specialist clinicians have difficulty in understanding genetic test reports. There's a body of literature to that effect. And so what we did was we undertook user-centered design and actually generated recommendations for designing genetic test reports that can be understood by patients and non-specialists. And we went ahead and tested these new reports against the standard of care reports that are still currently in use, and showed that these new designs are actually they exhibit greater communication efficacy to non-specialist clinicians and patients. Therefore, we believe that these would be more actionable. So if you're interested in this, you can just check out these publications. I know that there's been work in Australia actually to implement similar efforts. And then I just want to touch on a big program of work that's currently very much about to start in the UK, which is our the Newborn Genomes Programme. It's actually called the Generation Study now. And this is a research program being run by Genomics England. And this is looking at sort of whole genome sequencing in the newborn period. So we currently have quite a modest newborn blood spot screening program in the UK, screening for 9 conditions. It's been recognised that there is potential to expand our newborn screening program. So the Generation Study is looking at sequencing newborn genomes and has 3 aims. The first is to look at screening in the newborn period using genomic testing. The second is to look at understanding how this data can be used for research, and thinking about what it would be like to store a genome over the course of a lifetime. And so that's the 3 aims of the study. And parents have to opt into all 3 aims. You can't just have the screening bit and not the data retention. So this, again, just important to emphasize that this is a research study. This is not replacing the standard of care newborn screening program. It's running in parallel. So the study is due to start at the end of this year or very early next year, and aiming to sequence the genomes of 100,000 newborns. And there's an expectation that there will be a positive screening result in about 1,000 of those babies. So aiming to look at the clinical utility of genomic newborn screening, and also to look at things like the feasibility and acceptability of this, health economics, what are people's attitudes around newborn genome sequencing, and what's the impact. So the list of conditions that are going to be screened for initially has just been published. So if you're interested in that, there is an initial list of 223 individual conditions caused by genetic changes in over 500 genes. So that's the initial list that has just been published this month. That the aim is to look at those in the early stages of the project, but that list will evolve. It's expected to evolve over time. Okay, so I think it's also important to mention when we're thinking about the ecosystem of genomics in the UK, how important it is to have professional guidance in place. And so the British Society for Genetic Medicine has been quite active in this space over the last few years. One of the most impactful documents was this Consent and Confidentiality in Genomic Medicine guidance, and that really set the framework for the way that consent is being discussed within the National Health Service. So we actually talk about a discussion rather than a consent, and we have a record of discussion in terms of paperwork rather than a consent form. So the whole point is that this to emphasize the fact that a discussion should be happening with patients. Those guidance are currently being refreshed, but They have formed a strong foundation for us to issue guidance around genetic testing in childhood and in the prenatal setting. And then this particular guidance is all around germline cancer susceptibility testing in the prenatal setting. And then we've also recently provided guidance around the retention of genetic family records as well. So hopefully I've given you a bit of a whistle-stop tour of what's going on in the UK in terms of the sort of systematic efforts that are underway to implement a national genomic medicine service. We need to think about this systematically. The population is quite large, the healthcare system is quite large and complex. So we need to think quite systematically if we're trying to think about ensuring equity of access for patients to the service. We need to understand our systems and work with stakeholders to remove barriers. And again, I would say I can't underestimate how challenging this is. It's challenging all across the board, but I think particularly challenging when we're trying to do cancer work and trying to get a rapid turnaround time and really get those tissue pathways moving. We know that in order to provide this service, that mainstreaming is necessary. We need to have non-specialist clinicians doing a lot of this genomics work. We need to have them recognizing when tests are available for their patients and having those conversations with patients about genomic testing. However, this provides real life challenges. We know that many of our healthcare professionals really don't feel equipped to do this work. They don't feel that they know enough about genetics or genomics. They don't feel that they have time in their day to incorporate a different conversation with patients. So we really have to demonstrate the benefits to them because that's what's so important in motivating healthcare professionals. Really, if they can see the benefit to their patients, then they are much more motivated to adopt the change. So we have a huge amount of education and training of our healthcare workforce that's needed, and we need to be really innovative because people don't. We have staffing issues across the board in the National Health Service, and so we're asking people to do things differently. So we need to think innovatively about how this can be done. We need to be thinking about digital solutions as well, but also taking care of not to exacerbate disparities if we're doing that. So we really need to be thinking and listening to how we can actually implement services, not just tell people to do it. We need to do a lot of engagement work. Some of the research that we've done in the University of Cambridge shows that the actionability of genomic tests can be increased if we present the results in a way that's understood by the users. And by users, I mean both the healthcare professionals and the patients and their family members. So, I would really like to see more innovation in this area. I think that this is a scalable intervention where you can make an intervention in one place in the system, and that can really have consequences through the system. But there's a challenge in doing that. It would require laboratories to function quite differently, but it can be done. And I think I look forward to seeing more evidence emerge as to how effective that can be. And things like the guidance that's come out from the British Society for Genetic Medicine is just demonstrating how important it is for those who do have genomics expertise to provide policy and to anticipate future directions which can arise really quickly. So because we have a very strong political support for genomic medicine in the country, we have a really big sort of top-down driven approach where we're being told to implement genomics at scale through government policy and through NHS strategy. We have to look ahead and we have to think, okay, what are the things that are going to come down that pipe, and how can we provide some guidance so that this can be done well and it can be done safely for our patients. So it's important to step back and provide those policies so that they're in place when the mainstream clinicians really are looking for them. And I originally gave this talk in ICG in Melbourne in a genetic counselling session, and I myself am trained as a genetic counsellor. So, you know, I always like to talk about non-traditional roles for genetic counsellors and just sort of emphasise that there are opportunities to utilise genetic counselling skills beyond the clinic, influencing stakeholders to improve patient care. So that's the end of my talk. So thank you very much. And I think I'll be able to take some questions now.
Wonderful, Gemma. Thank you so much. That was just a wonderful tour of the Genomic Medicine Service and your implementation in the East. It was terrific. We've got so many excellent questions coming in, but I'm going to do the sneaky chair thing and ask one myself first. Very interested in the process of clinical genomic consent and the involvement of research. This is a discussion that we're having in Australia currently, and the potential risk for a patient being offered a clinical genomic test to feel coerced or feel like their care will be compromised if they don't agree to research. Can you speak to how well that has been accepted, and also from a temporal basis, is it offered at the time of clinical consent or some other time in the patient interaction?
So it's not actually specified how clinicians do it. So they can be separated in time and space. I think the pandemic really sort of challenged and helped to change the way that these consent conversations are offered. So, first of all, when it rolled out, is very much a kind of in-person signature on a form, wet signature on a form kind of model, but that really evolved with the pandemic, and a lot of these consent conversations are happening remotely. And actually, the consent conversations may even be happening in the whole by a different provider than the person who is ordering the test. So there's quite a lot of different models that are being implemented in different clinical situations. So the clinical, obviously, in order to for the clinical test to move forwards, the clinical consent conversation needs to happen, and that can be all in one with the research consent, or those two things can be separated, but the whole consent conversation can be somewhat separated as well in time and space. So some of those are happening remotely. Part of that is because just from practical purpose, if we're doing things like trio consenting with parents, not always you have both parents in front of you. So there's a real need to be able to provide that remote option. But your point around coercion, there is the patient has, the clinical test is not reliant on participation in research, and the consent framework has this sort of two yes/no boxes. One is I have discussed research, and the other is I would like to participate in research. So what you could imagine auditing this, and you could make sure that people were having that research conversation, but also you'd want to see a lot of yeses in that box to make sure that research option was being offered to everybody with equity. But you would want to see some no's in the uptake box, right, in order to make sure that there wasn't coercion. So that kind of gives us the opportunity to make sure that, because we have sort of two separate boxes, it gives us the opportunity to look at both areas, at both aspects of that, to make sure that it's being offered, but not being
taken up by everybody.
Yeah. So
interesting.
So you can have a look. The forms are, the record of discussion forms you'll find them online easily enough. And they very much follow the recommendations that were put together by the for clinical consent in the consent and confidentiality guidance. And then the research has been kind of tacked onto that, so that it's an all-in-one form.
All right. We'll definitely have a look. Okay, so we've got Michael and Alan both asking about primary care. So particularly in the context of mainstreaming and interventions, like in Australia with reproductive genetic carrier screening, the primary care workforce is critical. Can you speak to the engagement with primary care?
Yeah, so maybe one thing that I didn't mention in my talk is one of the initiatives by the Genomics Education Programme, which is called GeNotes. So we've actually got a just-in-time clinical resource called GeNotes, and they're rolling that out for different specialisms. And they have just recently launched that for primary care. So I was just training primary care clinicians the other day and showing them this resource, and that's actually quite helpful. So it's available for multiple different specialisms, and the aim is for it to be available for all different specialisms of healthcare. But it's, as I say, it's a just-in-time clinic tool, and it is very much scenario based. So, if you've got somebody who may have hemochromatosis in your clinic, or that's a service that's mainstreamed in the UK anyway, or cystic fibrosis carrier testing, for example. Those scenarios are all built into those GeNotes for primary care. So the very common primary care scenarios are there. We don't yet have, in the UK, in the National Health Service, we don't have expanded carrier screening yet, or and there hasn't been a huge drive on that, although we do know it's available in some private healthcare settings. I know that that's sort of being explored more in Australia at the moment. That hasn't been a big focus of our genomic medicine service to date at this point. But engagement with primary care, we are trying to engage with the whole system, so including primary care, absolutely. One of the things that comes up a lot in primary care is, or we think will be coming up more, is people walking in with direct-to-consumer pharmacogenetic tests. So that's something that's trying to be looked at the moment as well.
Yes. All right. Okay, that actually segues quite nicely to one of Regan's questions about screening. So we note that reproductive genetic carrier screening is not currently available. The whole genome sequencing in the Genomic Medicine Service is therefore largely diagnostic, is it? Are there other like adult cancer risk screening programs or other of those sort of predictive interventions being considered?
Oh yeah, no, absolutely. So just as before, you can have, sort of hereditary cancer predisposition syndrome testing based on family history. But then the other thing that's really picked up a lot is because we're doing tumor testing. So all tumors will be screened, or sort of colorectal endometrial tumors will be screened for Lynch syndrome. So actually a lot of the hereditary cancer predisposition syndromes is coming out from tumor testing. So it's a different model. So rather than having that family history drive being the driver for hereditary cancer predisposition testing, actually tumor testing and being able to pick up that somebody likely does have a hereditary cancer predisposition from the tumor, because we can see germline, a variant that we think would be a germline variant in the tumor. So with tumor whole genome sequencing, we are running a tumor normal control, so we can absolutely see germline variants. And then when they're doing panel testing in certain situations, as I say, with Lynch, there is sort of universal tumor screening for Lynch now. So that will be raising the uptake of that hereditary cancer syndrome testing, driven from the other side, from the tumor testing.
Yeah. Oh, I could talk about this all day with you, but I've got to ask some questions. So Bronwyn expresses her enviousness of the genomics education program and its quote unquote funded ability to commission courses across the nation. She's asking about the importance of university programs. Do you think that funded university programs were helpful or successful at upskilling a new workforce?
I think, yeah, so I mean, obviously I'm quite involved in running one of those programs, but what we have seen is they've been quite instrumental in bringing through the leadership, so from the different areas of medicine. So now a lot of our Genomic Medicine Service Alliance leaders, so our nurse leaders, our midwifery leads, or our primary care leads, our pharmacy leads, they will be people who were that sort of early on kind of took, a lot of those people participated those university programs early on. So I think it has been really instrumental in that respect, in really preparing the ecosystem. And yeah, no, I mean, I find it hugely beneficial because you know, you get those sort of champions in a service. So maybe you'll have one pediatrician who will do some modules of master's program, maybe a whole master's, or maybe just a few modules or a postgraduate certificate, whatever. And they will be the champion then in that hospital. So they will be the ones that are, you know, that try and get things going in their care team. So I think the university programs have been helpful in kind of seeding the champions through the system. So those people who know just a little bit more, who have a bit more in-depth knowledge and are therefore able to work alongside their colleagues and say, look, we really should be doing this. And so it helps to scale the interventions that the educators make, you know, and then it gives us something else to do. Like if we have one, you know, we may have an engagement session where we train somebody very specifically on a particular test, but really we'd like them to know a lot more than that. So then we can say, okay, let's go, why don't you go and take this and take that. And so yeah, I think it has been really, really helpful, and it really has created that sort of networking ecosystem. And a lot of the people who've been through those programs are actually in leadership, are sort of the champions or the leaders. They're the early adopters, they're the innovators, they're the ones who are kind of taking things out in their specialism. And a lot of them have actually have really taken on quite strategic roles. So
yeah, and I mean, you saw those champions in that slide with the different sites, right? With the, you know, some sites with lots of nephrologists or lots of neurologists ordering whole genome. So that sort of related to a question from Amy about the different specialties and genomic test requests. There were big differences in the doctor numbers ordering across hospitals. Cambridge is out front, then Nottingham, etc. Does that reflect the number of doctors in each location, or do you think there's some other factor?
So that reflects the fact that there are we have four teaching hospitals in the region. So those are the ones where you see Cambridge, Nottingham, Leicester, and Norfolk and Norwich in our region. So I think it makes sense that, you know, you sort of have your larger academic centres where you tend to have clinicians that are more kind of up to date or themselves more
proactive.
aware. So that's absolutely what you'd expect. That's where our testing laboratories are. That's where the bulk of our teams are based, to be fair as well. That's where our clinical genetic services are. So we have clinical genetic services in Cambridge, Leicester and Nottingham. So it's easier for them to reach their more immediate colleagues. So absolutely, I think they will be big hospitals. They are big hospitals. So it's not scaled. I didn't scale it. But it's they are big hospitals, but the reason for it, I think, is because they are the teaching hospitals where the clinical genetic services are located. So I think it's not coincidental at all, and it's what you'd expect to see. And then it's really what the aim though is to try, and I think what we're aiming to achieve with the paediatricians is really that reach out into the district general hospitals and the community care settings. And that's what we've been quite pleased to see happening in that specialism, where we've taken a more systematic intervention across the region.
Okay. Oh, I'm feeling so much pressure about which question to choose. So both Yvonne and Jason sort of speak to the genetic workforce capacity. So, you know, Yvonne's talking about 200 clinical geneticists, 300 odd genetic counsellors don't seem enough to implement mainstreaming. And Jason sort of speaks to the fact that paediatricians, you know, they're still uncomfortable with returning some of the more, you know, the positive results and their implications, and asks about the role of for clinical geneticists in the UK model, you know, and the fact there, you know, is there additional funding for these positions? You know, how is NHS building the capacity of the genetics workforce as well as mainstreaming?
Yeah, so that's really interesting. So I think where we felt the pressure the most is in the laboratories. So there's a huge workforce shortage of clinical scientists in the laboratories. We do feel because at the moment the laboratories aren't really quite managing to keep up with the testing demand. So even beyond thinking about yes, the genomic workforce will be supportive in further mainstreaming, but at the moment, the laboratories are where the crunch is in terms of workforce, and we're really trying to increase the laboratory workforce and think about how we can sort of work differently. In terms of clinical genetics and genetic counsellors, the service is now being nationally commissioned, and there's a service specification that's currently is in draft and hasn't been issued yet, because they're just trying to cost the service, I think. And that will sort of define what their relationship is with mainstreaming and what the expectation is on the clinical genetic services to be involved in mainstreaming, etc. But I do anticipate that there will be a real emphasis on equity of access, which has not been really something that's been measured in clinical genetics previously. So that does reflect that role that they will, that they have sat in large academic centres and really dealt with the referrals that have come into them, whereas they will be tasked with more equity of access delivery. So that, I think there will be a change in how they work. It's quite exciting when you see some of these things kind of springing up. So for example, in our region, we had a pediatrician come through the master's program, and then their team really got involved, and they invited us to give a tour, to give a sort of an evening presentation out in their hospital. They invited their hospital strategy directors along, and now that hospital is got funding for 5 years for a genetic counsellor in a district general hospital. So I think you're starting to see genetic counsellors actually working in mainstream settings outside of clinical genetics, and so we've seen that in a few different specialisms like cardiac genetics or eye genetics around the country. A little spattering of it, but I think it's going to be really interesting to see if we see genetic counsellors actually seated in district general hospitals. I personally would be really excited to see that. I think that will really, where they're supporting healthcare, there's other healthcare professionals. So the other healthcare professionals are mostly doing it, but the genetic counsellor is there to sort of support and see any more challenging cases, but also providing that sort of consultation with a whole range of genetics professionals. I think that would really help drive equity of access for patient care, and is perhaps more scalable than trying to see all the patients.
No, I think that's an excellent point to stop. I'm so sorry to those I didn't get to your questions, but we will wrap it up. Gemma, thank you so much.
No worries.
Get on and start your day. Probably have another conversation. But no, very grateful for you joining us today. It's been just wonderful to get that journey through the NHS Genomic Medicine Service in the East.
Thank you so much for having me.
Pleasure. And thank you all for joining us this afternoon to speak with Gemma. I hope you found that a really enjoyable and informative talk. Our next DNA dialogue will be on Thursday, the 7th of December, and will feature Dr. Victoria Nembaware of the University of Cape Town. So I hope you can join us then. Thank you.